This is Addiction Medicine Journal Club. I'm Dr. John Keenan.
And I'm Dr. Sonya Tredici.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. And now we are offering Category 1 CME through MyCares in Michigan State University. The link for the CME is in the show notes. This week we are going to be discussing an article on the protective effects of buprenorphine and fentanyl overdose. How are you doing today, Sonya?
I'm doing fine. I'm laughing because we've been recording for a little while this evening and I got stung by a bee earlier. So that was the excitement in the last recording we did, but I'm recovering nicely.
And you have bee anaphylaxis. So you cheated death tonight to be here with us.
I cheated death to record this podcast. I can't think of a better motivator.
And you took a handful of Benadryl. So if you fall asleep, we're going to give you some grace tonight.
Thank you. And you were on call. So we're about even in terms of our energy levels.
It's a one. It's a one on the speaker, yeah.
No, this article is so exciting. It's going to keep me awake.
So what have you been thinking about this week in addiction medicine?
Two things. One is I just wanted to, before we get going, to thank our listeners, especially people who have sent in comments about the articles. We really do want to know what you think. And I hope that people will continue to send in their ideas and opinions because sometimes I feel personally a little undereducated about addiction medicine. I really wonder what people at different institutions are thinking and what they're doing and if I'm kind of meeting practice standards. So if you have thoughts about anything we've said, don't hold back. Send them in to us. And there's a bunch of ways to reach us. You can email or put comments on all the social medias. Or if you're a Spotify listener, there's a little comment box right on the podcast. You can stick a comment in there right as you're listening. It's very easy. And I just love to hear what people think. I always want to learn more, and our audience has a lot of good ideas.
That's awesome.
In terms of addiction in the news, I kind of wanted to talk about news that wasn't. So, I don't know about you, John, but I am desperately waiting for clinical trials that show that semaglutide will reduce alcohol consumption, that we can use it for alcohol use disorder. I wish that would be true. And I really want to see a trial for that. We're getting closer. I did see a case series that was published in the Journal of Clinical Psychiatry. And so it was just a case series. So it was 6 patients with alcohol use disorder, and they significantly reduced their consumption when they went on semaglutide. Their audit scores went down significantly. And I've heard that anecdotally from my patients who are on semaglutide. They have reduced their alcohol consumption. But honestly, I've never given it to anyone who was in the middle of struggling with alcohol use disorder and struggling to reduce their alcohol use. I've only had people say anecdotally they don't want to drink so much, but they also don't want to eat so much. So I have never really talked to anyone about alcohol-specific cravings. John, have you seen anyone give up alcohol when you started them on semaglutide or any of the other GLP-1 agonists?
It's interesting. I see more and more buzz about this. I haven't prescribed them for that indication, although anecdotally, there is a patient that we take care of quite frequently that is in the hospital several times per month for alcohol-related complications. And for a period of time, that person was on semaglutide for a medical indication. And it's interesting, they were actually not presented to the hospital during that period of time. And then their insurance stopped covering it, and now they present again. So I'm not sure. That's an N of 1, but I think it's an interesting idea, mostly because of desperation of our pharmacotherapy for alcohol use disorder, which, it's better than nothing, but it's not as robust as the stuff that we have for opioid use disorder. It's just not as effective.
Yeah, agreed. Well, and it's an injection, a once-a-week injection, so there's not so much of that feeling like people stop taking their meds, which is a problem with other medicines for alcohol use disorder. It has positive benefits in terms of diabetes and obesity, which are both big problems for our patients with alcohol use disorder as well. So I'm just waiting. So I'll put the link in the show notes to this case series of 6 patients. But if anyone out there is doing research on semaglutide and alcohol use disorder, or you have a patient that you've worked with and you've seen effects, I'd love to hear about it.
Yeah, it certainly seems like it's like the new statin. It's got approval for everything.
That's right. Everything. So, John, are you ready to hear about my article?
Yeah, this one seems really cool.
It was really cool, and I'm super excited to talk about it tonight. So, the article is titled Quantifying a Potential Protective Effect of Buprenorphine on Fatality Risk During Acute Fentanyl Exposure. It was published in the Journal of Substance Use and Addiction Treatment in 2024. A little bit of background. We know, and this is why we do it, that patients who are prescribed buprenorphine have lower risk of opioid overdose death. Buprenorphine helps patients with withdrawal and cravings from opioid use disorder and enables them to use fewer illicit opioids and licit opioids. And in this way, because they're using fewer opioids, they reduce their overdose death. It's because if you're not using them at the opioid, you're not as likely to overdose on said opioid. And so that's sort of how I've thought about it in the past. But there's another way that buprenorphine protects against overdose death, and that's by blocking the mu opioid receptors themselves and directly preventing the lethal effects of opioids, especially synthetic fentanyl, if a patient were to take it. And so basically, in general, for 1 year of buprenorphine treatment, the number needed to treat to prevent one death is about 53. And I've always thought that that's just because people aren't taking the opioids, but really this article explains it in kind of a different way. And so I chose this article because I actually wanted to choose a different article, which I didn't present because it's more experimental than clinical, and it was published in January 2022. It involved bringing people into the lab and giving them increasing doses of IV fentanyl until they stop breathing. And, they also had people on buprenorphine or not. And they showed that the people who were on buprenorphine had much less respiratory depression from the fentanyl than the people who didn't. So that study wasn't really practice changing for me because I'm not bringing people into the lab and giving them boluses of IV fentanyl or IV buprenorphine. But it really made me realize there's something more there than I was thinking. And this paper really demonstrates more real world clinical data to show that same effect. So I'm going to quote the authors. They said that data from this study, they really aim to provide clinical evidence that buprenorphine reduces the harmful effects of fentanyl on ventilation and protects against fentanyl-induced respiratory depression in a concentration-dependent manner. And that's why I decided to prevent it. I just was really interested in this whole way of thinking about overdose prevention. John, before we move forward, had you thought about overdose prevention that way, that the mu opioid receptors would be physically blocked so people would have a harder time overdosing if they did take fentanyl? Or were you thinking about it more the way I was, like, oh, well, they're not taking fentanyl, so they're not going to overdose?
I always thought about like that has that partial agonist effect. So it kind of saturates, protects, sort of like when we treat acute pain on top of it, that there's like a cap on the respiratory suppression. I also think that similar to methadone, that you're not totally losing your tolerance, right? I think loss of tolerance seems to be a big source of fatalities for a lot of these patients, right? So prolonged period of abstinence where loss of tolerance leads to kind of like resetting of the opioid receptor, kind of respiratory suppression bar, and then relapse produces kind of like serious adverse events at a lower dose than previously would have. So I've always thought of it as like twofold like that. But you're right, they're not using two or as much. I don't have a ton of patients that I'm seeing that are like on a moderate to high dose buprenorphine that are coming back to see me that are still using all the time. Like I think that most times once they're on treatment, I'm not seeing a ton of that. I guess the group loss to follow up, I would assume is, but that's not a humongous portion of my patient population, thankfully.
Yeah, no, mine neither. But I think also it takes a certain level of organization to get outpatient treatment. You got to come to visits, you got to go to the pharmacy, you got to be relatively organized. And it's hard to do that if you're using a lot of like IV drugs. Anyway, clinical question. The basic clinical question in this trial was, in patients who died of a fentanyl overdose, is there a difference in the fentanyl blood concentration between those who also had buprenorphine in their systems and those who did not? The population was people in West Virginia who died of an unintentional fentanyl overdose between 2011 and 2020, and that was 3,036 people. The intervention, the thing they looked at was the presence of buprenorphine in toxicology postmortem, and they compared it to people who had no buprenorphine in their system and postmortem toxicology. The primary outcome was the fentanyl concentration in their blood. So basically, they were looking at whether people who died of a fentanyl overdose, was their fentanyl concentration higher, lower, or the same if they had buprenorphine also in their blood. They did try to adjust for a bunch of things, including other drugs found on toxicology, the concentration of buprenorphine and norbuprenorphine. So, trying to figure out whether people had taken it long term or whether buprenorphine was part of a short term kind of multi substance binge that contributed to overdose, or whether they were on long term buprenorphine. And they also adjusted for some comorbidities, demographics of patients who did and did not have buprenorphine in their toxicology. The secondary outcome was, like I said, a buprenorphine to norbuprenorphine ratio of less than 1, which is an indicator of long-term buprenorphine use. So they looked at whether long-term buprenorphine use was associated with fentanyl concentration compared to presumably short-term use. And for anyone who doesn't use norbuprenorphine, just to let you know, buprenorphine is a very long elimination half-life. So if the metabolite of buprenorphine is present, which is norbuprenorphine, it indicates your buprenorphine was taken 2 to 3 days prior, rather than being involved in just an acute overdose, within that day. So what did you think of the clinical question, John?
I thought it was interesting how they did that. Although I was kind of taken aback by thinking the first thing was like, poor West Virginia. I feel like it's always West Virginia with these trials.
Well, I mean, I'm glad they're doing research. There's just so much drug use in West Virginia, who is our neighbor, basically. Yeah, hopefully they're doing a little better now.
Yeah, it's a morbid way of looking at the question, right? But I think it is an interesting way to do it, right? From postmortem analysis. I'm interested to see what it shows.
The next thing to talk about is whether this is a valid trial. So this trial had both strengths and weaknesses. I thought it was very strong, and I did think it was a valid trial. So some strengths. First is that this was a very relevant clinical question. Great clinical question. Second strength is that, we're looking at exposure to buprenorphine and the outcome of death. And that connection is plausible. It's been shown to be true in other contexts that people who take buprenorphine have less death. There was a large sample size, so over 3,000 decedents in this study. And also the West Virginia Office of the Medical Examiner, they perform pretty consistent toxicology screens throughout the study period. And that's been a barrier to other studies of postmortem people, that the different medical examining offices do different toxicology. But in the state of West Virginia, they were pretty consistent, and they looked for buprenorphine, norbuprenorphine, fentanyl in the same ways throughout the study period. They got some quantitative measures from this comprehensive toxicology database, and it was funded by the NIH and NIDA, which I think are unlikely to cause bias. There were some limitations of this study. First, it was in a single state, so perhaps not generalizable to other areas or populations. We didn't have the buprenorphine norbuprenorphine ratio for all patients. That toxicology, while it was done the same when it was done, in some places it wasn't done at all. The other downside is that this is just of people who've died. So we don't have prevalence data of buprenorphine use or fentanyl use, and we don't have data on those people who did not overdose. We only have data on people who did overdose. So it might not be representative of the population who is alive. There might be something about those people who died that's different from the people who were alive, who survived, and we don't know what that is. It was, of course, retrospective cohort study rather than a randomized controlled trial. If we wanted to do a randomized controlled trial, we'd have to go back to that trial that I talked about where people were in the lab receiving fentanyl till they induced respiratory depression. Finally, because again, it's a retrospective cohort study, it's not clear that people who had buprenorphine present at death were the same as those who did not. So there might have been some other protective factor in the buprenorphine other than just the buprenorphine itself. But I did think it was a valid trial despite some of those limitations. What about you, John? Do you think it was valid?
Yeah, I mean, it's interesting. It's an association, right? So
Yeah.
there's no causation here, but I mean, that's the first part to kind of develop a theory here.
So let's talk about the results. In terms of people in this trial, we had 3,036 people in West Virginia who died during the study period. Their mean fentanyl concentration in microgram per milliliter was 0.028, and the median was 0.017. And I think median is maybe slightly better than mean because there are probably some outliers, a few people who had very, very high levels. So our primary outcome, when buprenorphine was present, the median fentanyl level in people who died was 0.028. So about higher than the median for everybody. When buprenorphine was absent, the fentanyl level was 0.017 micrograms per milliliter. And that was statistically significantly different with a p-value less than 0.001. So again, if there was buprenorphine in your system, your fentanyl level was 0.028 micrograms per milliliter. If there was no buprenorphine, it was 0.017 micrograms per milliliter, your median fentanyl concentration. So again, you had to have higher fentanyl concentration to die from a fentanyl overdose if buprenorphine was present in your system. They also looked at these subgroups, those with the buprenorphine norbuprenorphine ratio less than 1 and greater than or equal to 1. It was a small subgroup. There were only 19 people where they had the buprenorphine norbuprenorphine ratio and it was greater than 1. And those people had about the same fentanyl concentration as people who had buprenorphine present in their systems, but it was a very small subgroup. The buprenorphine norbuprenorphine ratio less than 1, which indicates chronic buprenorphine use, they had an even higher fentanyl concentration than people who had used it maybe just once or twice prior to their overdose. So the group that had the very highest fentanyl concentration was people who had chronic buprenorphine use prior to their overdose death. And that's the primary outcome.
That's sad. That's a lot of people. That's a lot of death, right?
Yeah, in a very small state, you know?
Yeah, and I think the thing that kind of strikes me is, first of all, it's very interesting, right? That there does appear to be a protective effect here, or at least from this kind of data that's being presented here, or at least there's an association with protection. If I think of the 2,868 without buprenorphine present, what a kind of a missed opportunity for like life saving intervention, right?
Yeah. Well, I think that's the hard part. Whenever we look at any trial of opioid use disorder, there's always this group of people who are not getting treatment at all. And it's always very painful to think about. And it's not necessarily that they can't get treatment. I mean, most people in recent data who would want treatment get treatment, but there's a lot of people who are just so sick they don't go for treatment. There are other results in this study, and there's some very pretty curves, which I'm not going to really describe, but I'll just have people go to the paper if they want to see it, or maybe I'll screenshot the curve on social media. But there's just some nice curves showing kind of a right shift in the presence of buprenorphine. So if buprenorphine is present, a higher concentration of fentanyl will be needed to reach a certain percentage of population who died from that fentanyl use. And again, I will refer people to the paper to see that curve. The final table was a lot of the factors they tried to adjust for that were also present in people who passed away. So they wanted to see what other factors might have been associated with higher fentanyl concentrations, with lower fentanyl concentrations, or had no relationship to the fentanyl concentration. I thought this was also really interesting. Although again, the study's not necessarily designed to see if these are really causative, it's just correlation. But other things that were associated with higher fentanyl concentration, meaning they're protective. So buprenorphine, a buprenorphine to norbuprenorphine ratio less than 1, meaning long-term buprenorphine, a history of substance use disorder. So those people had higher fentanyl concentrations. Yeah, to me, that was like maybe because that means they're more likely to be in treatment. And finally, if there was marijuana present in their toxicology, that also was associated with higher fentanyl levels, possibly being protective. I don't know why that would be. We talked about in our journal club that the marijuana is a CYP inducer and it can increase the potency of your buprenorphine. So buprenorphine levels might be slightly higher in the presence of marijuana, which might lead to a protective effect of taking the two together. But that's very, very, very speculative. Some things that were statistically significantly associated with lower fentanyl concentration, meaning you were more likely to die, is BMI greater than 30, being male, having alcohol present, and having cardiovascular disease. And finally, factors that had no relationship to fentanyl concentration. One was short-term buprenorphine use. So if you had taken buprenorphine, but it hadn't been metabolized, other opioids didn't make a difference. Benzodiazepines didn't make a difference. And having stimulants in your toxicology did not make a difference on your fentanyl concentration. So what did you think of those results, John?
I think the marijuana one kind of does kind of jump out at you, right? Like what's going on there? And certainly I see a lot of people in recovery. The term they use is California sober, where they still smoke marijuana, and they tend to do a lot of it. And I sometimes I wonder, maybe this is just the nihilist in me, but I'm like, is it just that they're smoking weed all the time now? They don't have time for other drug use. I don't know, but it seems like there does seem to be something there.
Yeah, I mean, it's there in this data, so we'll have to look. Maybe they'll, if these studies get repeated or what, maybe they'll do one of those studies where they bring you into the lab and give you fentanyl and then give you THC instead of buprenorphine and see what happens.
Well, there has to be high quality evidence that it's protective because it's one of the indications for medical marijuana. So it's definitely some grade A evidence for that condition. I'm sure there must be somewhere.
Somewhere in the Pennsylvania State House. So, will these results help me in patient care? Just to summarize, buprenorphine presence was associated with a significantly higher predicted fentanyl concentration in people who died compared to when buprenorphine was absent, suggesting that when buprenorphine is present, higher doses of fentanyl are needed to result in a fatality. This finding provides the first quantitative evidence of buprenorphine's risk reduction for fatalities that's been suggested in earlier experimental studies. So, my patients are similar to those in this study demographically. The treatment, which is buprenorphine, that's feasible in my setting. The benefit, which is not dying from a fentanyl overdose, is a clinically relevant benefit. It's likely of value to my patients. And they didn't really discuss any harms of being on buprenorphine or harms of taking buprenorphine along with your illicit fentanyl. So I can't really weigh benefits versus harms. But I would say, in conclusion, this article has changed my thinking about why being on buprenorphine is protective against overdose. And it has led to some actual changes in behavior, in that I really do everything in my power to keep my patients in treatment if they're at risk of using illicit opiates. And I've also started to push for injectables more for patients who are unstable and who are using, so that even if they want to use the fentanyl, they will be protected. Even if they, with the oral buprenorphine, the sublingual, I worry people will just stop using it and their protection will quickly fade. And so it has changed my behavior a little bit in terms of thinking of the buprenorphine itself as a blocker of the fentanyl rather than just something that keeps you off the fentanyl.
It's an interesting way to kind of rephrase thinking about it.
For sure.
Yeah, I think you're right. Kind of as long as you're on treatment, right, there is protection to a certain extent.
Well, thank you for listening to me.
Recruit more prescribers, everyone.
Yeah. Yeah, if anyone out there wants to prescribe buprenorphine and you don't, feel free to send us an email. I would be happy to chat with you about how you can save lives and make your patients happy with buprenorphine.
Well, thanks for the article, Sonya.
You're welcome.
Thank you for listening to the Addiction Medicine Journal Club. The best part of any journal club is the conversation, and we want to hear what you have to say. To have your opinions about the article included in future episodes, send us your comments. The links are in the show notes. Original theme music was composed and performed by Benjamin Kennedy. Audio editing by Aaron McHugh. CME support from My Cares, produced by Dr. Patrick Beeman and Ars Longa Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation and have a great day.